I am Dr. Stefan Kais of San Antonio. This is my office. As you can see, that's where I reside. And if you can see on my left-hand side is a picture from early 80s courses of Andreas Granzig, who was my first mentor. And that's how I started. I'm also a clinical professor at the University of Texas Health Science Center, where I work with William Palmas and Steve Bailey for many, many years. And we have our own outpatient center where we do pretty complex interventions, both cardiac and peripheral. I'm very grateful to Jan Skowroński for putting this together. And congratulations to the organizers. I'm honored to be part of this. Thank you.
Good evening. My name is Przemysław Nowakowski. I am a vascular surgeon from Poland. I live in Katowice and I am a chief department vascular surgery, American Heart of Poland in Chrzanów. My topic is connected with using radial access for carotid artery stenting. And now we are in our research department. Thank you.
I am Łukasz Dzieciowicz from Zielona Góra, Poland. In English, Zielona Góra means green mountain, which is actually only half true. There's no mountain here, but there's a lot of forest and green parks where you can enjoy fresh, healthy air, which is good not only for Claudicans, but for all of us. Moreover, Zielona Góra is a capital of the region in Poland that has a winemaking tradition, which is not common in this country. And every year, at the end of the summer, there's a wine festival in the city, which is strongly recommended to see and participate, of course. So, Zielona Góra is a place where you can have a good treatment for vascular disease, enjoy fresh air and green forest, and taste a good local wine. Welcome to Icarus.
Good evening to all of you in Warsaw and around the world. I'm Gary Rubin, Cardiovascular Associates of the Southeast, Brookwood Medical Center, Birmingham, Alabama. I'm quarantining now at my home in Jackson Hole, Wyoming, under the beautiful Teton Mountains. We're in for a wonderful carotid intervention session. I look forward to seeing you in a few minutes.
So let me introduce my friend and mentor, and I'm proud that he's my friend, Dr. Gary Rubin, who is a legend in interventional cardiology. But I think people who will have tough time doing the work during the session today are the translator. Gary is Australian, and good luck to the translator. But as I said, Gary is a legend. Gary developed the first ever coronary stent. So we'll say hi to Gary, and then we have Stefan Kais from San Antonio, who is also a legend, and he's actually very interesting because he's absolutely amazing operator from head to toe, and he built cath labs in Poland. They have Polish-American heart clinics. They have 30 cath labs, but Stefan never really speaks in Poland as far as I know, and he has plenty to say and gives great lectures. I heard him here, but not in Poland. So Gary, now back to you.
Okay, can you hear me, everyone?
Yes.
Great. Okay, well, welcome everyone to the last and I think a very important session for Icarus. Congratulations, Jan, all the organizers for putting this together. I'm going to hand it over to Stefan now, and then I'll bring my slides up and we can regroup a little after Stefan has given the opening quick talk. Thank you.
Thank you, Gary. It's so nice to see you. The last time I saw you, I think it was in Sydney at the International Congress. I presented some crazy stuff with on stage bilateral carotid stenting, and you were defending me, and somebody was attacking me quite a bit. But
good to see you too. So welcome. Yeah.
But you remember my first trip to Birmingham when you were starting this affair with stenting, and then I learned from you, and then Julio and I and somebody else did the third case. Anyway, Jan, this is a fantastic endeavor, and congratulations. And you pulled this even during the COVID-17. As you can see, me and Gary did not wear the mask. So let's start from the first slide. This is a case which was done very recently. I've done several hundreds of those, if not over 1,000. And it was a nice day. Go ahead. This is our typical patient who we have in San Antonio. He had carotid artery stenosis, he had the renal artery stenosis, he had coronary artery disease, PAD, you name it, cardiac pacemaker. And he was symptomatic. He is Medicare patient, symptomatic. Within the last 6 months, he had a TIA, which was a transient aphasia. So he fulfilled all the criteria, so you get paid for the case, and the hospital gets paid for the case. That's the only procedure which I will do in the hospital. I don't do carotid stents outpatient yet. See, this is his medications. And of course, in our non-invasive lab, this is significant carotid stenosis. You can see the PSP is 3.5 meters per second. Internal carotid EDV is 1.1. So you know, this is real stuff. Let's play the angiogram. As you can see, one of the criteria when I will refer patient for surgery, if I see heavy calcifications, that would really discourage me from stenting. But this looks like a very straight shot, beautiful. So we use my favorite stent, the closed cell design exact stent. This is Abbott system with the Embo shield. Let's go. So I thought it will be 5-minute case, and I was whistling, and let's go farther. You can see that we have a filter already there, and obviously predilation. Regarding the predilation, we have to be a little careful. Go back, please, because you don't want to predilate with too big balloon. You can create a dissection, lesion didn't look like it's a non-compliant lesion, and I thought it would be a very easy case. You can see the liver systems here, and then I delivered the stent, and then I couldn't get the liver catheter out of the stent, and I was pulling on the patient carotid, and I was looking at him, he was squeezing the duct on the opposite side. I couldn't get the damn catheter out of the stent. I was scared to death. Then I kind of composed myself and asked him to turn his head to the right, to the left, and gently put the sheath as gently as I could. It was not as gentle as I'm describing. You can see the stent is a little mangled here on the bottom, and I was able to kind of sheath this and release the delivery system from was stuck somewhere in the struts. What I think happened is the lesion was very non-compliant. It had quite elastic recall. Even that I have reasonable predilation. When I delivered the stent, I couldn't get the delivery system out of the stent. Obviously, so the last thing you do in a situation like this, you don't panic, but you turn the head up and down. Sometimes you can ask the patient to put chin down, up, and if you can, you want to put the delivery sheath inside of the stent and gently remove it. Don't use any force, because then you can really kill the patient on the tape. So this is where we finished. And next slide, please. So that was, my scrubs were sweaty. I was very relieved that we did not end up with the disaster. So caveat is, whatever and this is the only time I had a situation like this which happened. I also think if there will be open cell design, I would have much more problems than I have. And the closed cell design actually is in my opinion, is my favorite. So we're able to remove the elbow shield, and at the end, next one, please. As you can see, we avoid any disaster. The cerebral circulation actually is intact, and patient was discharged the next morning, and he's asymptomatic. So this is the real stuff, which we do quite often here, and this is our center when we do some other things, except for carotid stenting. Thank you very much.
Thank you, Stefan. So I think, Will, you can throw that back to me. That's a great case, Stefan, and showing great skill in knowing to bring that sheath up and just gently, wriggle the head and neck around, and you get loose. And you're right, it's a very rare. I think I can recall that happening in a few thousand cases at least once. But yeah, good to know. And take your time, and they always come loose. Always, yeah. Okay, well, I'm going to bring up my slides here. All right, so great to be on Icarus. It's nice to be here. You can see I'm in my log home in Jackson, Wyoming, and there's a photo of a wonderful, the crowds were gone this year, so the bears were out. This is a very famous female, been around for about 26 years, and she had 4 cubs this year, and we were able to drive up and get some photographs of her and her brood right by the road. So come visit anytime. I'm out here most of the time these days. I think what we need to talk about with carotid stenting is really the state of the science, and I'll address that. We can all talk about that. Stenting versus endarterectomy, stenting versus medical therapy in asymptomatic patients, and stenting now versus TCAR, which is an interesting technique, which I think has a very important niche role in this revascularization. The other really critical issues for this, as advertised, less than 1% risk of anything happening is really lesion selection, patient selection. I'm going to address that in my presentation. We can talk about current best technique and the status of new technology, which has not evolved much, but will start to change in the very near future as we see better technology coming to help us with our work. I want to give you this case. It's a real issue in my carotid stenting practice. Female 71, asymptomatic, past history of smoking, typical hyperlipidemia, hypertension, previous coronary bypass surgery 3 years earlier. She presented with carotid duplex findings. The cardiologist that was treating her was worried. It said it was a 70% stenosis. Her ratio, her velocities were 264 over 53 with a ratio of 2.3. She was taking a low dose of statin, some blood pressure medicine, candesartan, and 81 of aspirin. She was obese. She was hypertensive with us, but she was also had home records, and she was hypertensive at home. She had loud left carotid bruit. She had absent distal pulses. I suspected she had also severe PVD. So the initial management was to reassure her that there was no need to rush into anything. She was asymptomatic. Her disease, in my view, was moderate. We discussed medical therapy, and we discussed, most importantly, the CREST-2 trial, where we at Brookwood Baptist in Birmingham are in the top 3 centers recruiting patients into this trial, as I was in Act 1 and the CREST-1 trial. So I started her on what I think is the minimum of best medical therapy, which is high-dose statin. And I think every patient having stenting should be on that. Rosuvastatin 40, up the dose of aspirin, add clopidogrel, and put her on another blood pressure medicine, because we know that control of blood pressure is extremely important, as well as controlling LDL in our patients with carotid disease. Now, I ordered a CTA, which is what I do, home blood pressure monitoring, really admonished her about cigarette smoking. I said I'd see her in a month. And we talked more about the CREST-2 trial. She came back, her blood pressure was better controlled. I got a good look at the arch and the lesion. She had a 70% stenosis. The radiologist at CTA is always at least a 70% stenosis. That was non-calcified, non-tortuous, and certainly suitable for stenting. With the discussion, the patient wanted to continue medical therapy, was very interested in the CREST-2 trial. There were a lot of advantages for patients being in that trial. So I said, okay, let's get you back in 6 months. If nothing changes, if anything does, let me know, and we'll get a duplex. So she returned in 6 months, and she'd been smoking. She'd not quit her cigarettes. A duplex was 340 systolic over 107 diastolic, and still, it's very important in the CREST-2 trial that we include these patients. She was still asymptomatic. We're not going to be able to prove that Revasc is better than medical therapy if we only recruit the patients with moderate disease. She did agree to participate. And this is important because it includes this monthly follow-up by the CREST-2 team for smoking counseling, targeted blood pressure. They remind us to put them on more meds, to drop the LDL even further, nutrition, weight reduction, counseling, monthly follow-ups. It's a great program. I really believe that's our first choice for asymptomatic patients. This is a duplex, and you can clearly see these very high velocities. This lesion, I knew, had got much worse. And so she was in the trial. She was randomized to, fortunately, I felt more comfortable. She was randomized to stenting in this trial. And this is what I found on the angiogram when I was bringing her in to stent her. So now you see she's progressed to this something like a 90% stenosis, and this is non-calcified. This is soft, gromosy, liquid material. And so this is a very high-risk lesion for these patients. And so you have to use very careful technique. It's my standard technique. So again, like Stefan, I used a free wire NAV6 embolic protection system. I did consider using the proximal occlusion, but I find the technique I'm going to describe now, which I've used almost exclusively for the last 5 years with 0 strokes, is what I'm going to share with you now. So when I deal with any lesion, I always work on the seatbelt and airbag system when considering embolic distal protection is not enough. So you could use proximal occlusion systems with flow reversal, but once you take that or a filter out, if you don't use the technique that I'm going to propose, you end up with a lot of material squelching, squeezing through the stent struts. So I always use closed cell stents, but for the last number of years, I have used this 2 closed cell exact stents, one inside the other. I believe the future of carotid stenting will be some type of very closed cell covered flexible stent. There are those coming on the market. We'll have them soon. There are more coming, and that will change the paradigm. But for now, this is my technique: 2 coaxially placed 10 by 30. And it's important to use a 10 millimeter stent because in the 5 millimeter internal carotid, you get much smaller cell size. So 2 exact stents. Look at the fine mesh that's excluding any possibility that this fresh, soft material can extrude through the stent. and one gets this beautiful result. And most importantly, one gets no neurological adverse outcomes, which is what carotid stenting is all about. So I gently kiss this with a 5 millimeter balloon, one single inflation, never a balloon bigger than 5 millimeters. It's a gentle kiss, and that's the result that we can expect. So I just want to throw out a curveball, something different, and let you know what my practice has been for a number of years. And it's if the lesion had looked not like the straight upgoing lesion that we'd seen, but a lesion like this. And this is the mistake we made in CREST, where we used open cell stents, and in Act 1. But particularly now, we have to stay away from these very large open cell fish scaling. And in fact, if this patient had had a lesion that looked like this, I would have randomized the patient in the endarterectomy arm of the CREST-2 trial. But imagine now you take this cheese grater, then you straighten it out with a balloon, and then you take the balloon out. This is the perfect storm for embolization. And regardless of if you have a filter, there will be particles getting to the brain. There may or may not be, but there is a chance, perhaps up to, as we saw in CREST, 2 to 3% chance of a minor neurological event, which will count against us. So I'm going to stop there. We're going to open this up for discussion, and we can move on and talk about all those things that we've talked about in this brief case presentation. Thank you. So,
Gary, this is a fantastic presentation. Let me just make a comment. I just, like this last case which you refer for surgery, I did the same exactly thing for the same exact reasons.
yes.
Now, the one caveat which got me out of the soup before I became so intelligent in terms of what to refer where, I was in a situation when the filter was full and there was open cell design extent. I was able to essentially go with the aspiration catheter because I knew when I get this umbrella folding, then I will be stroking the patient. So that's one thing which sometimes when you get yourself in the soup like this, and you have a cheese squeezed out, aspiration catheter at least gives you some solution.
That's a very, very good thing, Stefan. Of course, I think that better still stay away from these lesions.
That's right. Oh, absolutely.
But if it's straight, then I think this fine mesh is the answer, much more than embolic. In fact, the embolic protection is in the stent. That's
right. That's correct.
The material. So that's the future. So yeah. So Jan, we have another presenter, and it's getting late in Warsaw. So perhaps we should move ahead, then discuss more.
Okay, thank
Gary?
you. And Grzegorz will be moving to Ivo Petrov from Bulgaria.
Yeah, Jan, before Ivo will start, I want to present also other our colleagues. I want to introduce Piotr Musiałek, Professor Piotr Musiałek from Krakow, Ivo Petrov from Bulgaria, from Sofia, Professor Dziedziuchowicz from Zielona Góra, from Poland, and Doctor from Chrzanów, which is very difficult name, from Poland. Okay, so yes, please, Gary. I'm a little bit sorry, but I wanted to present the.
Oh, thank you
panelists.
very much, and yes. And do we have any comments from the experts that we have on our panel?
Yeah, Dr. Rubin, this is Łukasz Dziedziuchowicz from Poland. I have a question. You put 2 stents. Is it something like equivalent to a mesh stent, to a like road saver or something?
Yes, it is. Thank you for asking that very important question. I don't think this 2-stent technique will be necessary when the industry can provide us with this very fine mesh. And I think we already have 2, as you point out. One but there are more coming. And I think that that is the future. And we will be able to do this outpatient, less invasive procedure with patient wide awake and with close to zero strokes with this technique. This is the future. And thank you for asking that question. Yeah. So,
Hi, this is Dr. Mushawek. Can I join? Can you hear me?
Yes.
Hi, Dr. Rubin. Great to see you.
Good to see you again.
One particularly exciting innovation that is already available to us is combining an open cell frame, a largely open cell frame, which is the answer to some of those tortuous examples from you and from Dr. Kiesh, with a very fine mesh, a closed cell mesh that is outside the stand, that is non-metallic. So you avoid 2 layers of metal. And we are close to the recruitment of 500 patients now in our study. There's also other studies. There is an individual patient meta-analysis coming out in JACC intervention soon. And this looks really like you can pretty much avoid patient selection, because a lot of those patients you now refer to surgery can in fact be treated using the endo route with those novel devices.
They're wonderful. And it has the your experience, because this is always open label, but your experience is that this is really effective as a preventing any embolization.
The stents works as an embolic protector. So this is an embolic prevention stent, but you still need an embolic protection device to cover the timing of the procedure. And I believe Ivo, if you are with us, Ivo has pretty much similar experience. What we've been doing for the last nearly 5 years now is doing an all-comer study. So we track every patient who presents with the need of carotid revascularization in the opinion of a vascular team, neurovascular team. So there's a neurologist, there's a vascular surgeon, there is a cardiologist and/or an angiologist, and they confirm the indications. And then from our series, it is less than 10% of patients that we now send to surgery. Because you can bring so many of those patients who would have been a conventional surgical candidates, as you mentioned, high calcium, very soft lesions, tortuous arteries. You can really treat them safely using the endovascular path and, in a lot of cases, proximal protection. We are believers in proximal protection. The flow reversal with MoMA, we do not only stop the flow, we also reverse the flow like we used to do with the Gore device.
Very good comments. Yes, I certainly think that the answer is going to be these fine mesh stents or semi-covered stents. And I do think we still have a challenge with calcium, even with those devices. So that will still be a challenge. But yes, wonderful comments. Thank you.
We did recently actually analyze highly calcific lesions from the Paradigm study, and this is published in CCI. So with gradual preparation of the lesion, definitely those lesions need preparation. But with the radial force of the stent, you can really treat a lot of those patients that conventionally would have been candidates for surgery in an endo way. We have not had a case of perforation. This is a concern for some of the operators. And interestingly, the device that we have access to now in Poland, which is the micronet covered stent, Sigard, this device has been also used to treat carotid perforations. So the micronet has also got some sealing properties. You very properly named it a semi-covered stent. It is not a fully covered stent, so you don't get the downsides of the covered stent. There's no the squeezing of the debris on the both sides of the stent that was shown very nicely in the coronaries and in the bypass grafts. And there's not the problem of high restenosis rate that was the issue with those stents in the carotids in 2 trials. How close in the US are you from having access to those devices?
Yeah, we're still in FDA trials, so sooner the better. I think it will revolutionize and it's been decades since we've had any new technology here in the US. So you are very fortunate in Europe. Well, perhaps we're getting late. We should move on to our next presenter, Jan. Thank you.
Probably Professor Ivo Petrov has to start his presentation about carotid.
Thank you, Grzegorz. Ivo, you're on. I think you have a great lecture about doing carotid stenting from radial access. We have done some, but that's not our preferred route. And I hope we will have an argument between you and Dr. Gary Rubin and us here. Thank you.
Thank you, Jan. Thank you very much for this invitation. It's my huge pleasure and honor to be with you. And congratulations for the Icarusconference. We learned to be web-based, so this is the lesson from the pandemic. I will speak about a little strange, like escape from a difficult situation technique. This is the deep loop technique for carotid stenting. Nothing to disclose from my part. So I'm from Bulgaria, from Sofia. I'm working in a cardiovascular dedicated clinic, comprehensive one. Since 8 years of work, when we opened, we have more than 16,000 endovascular cases head to toe, including carotid artery stenting as a routine practice, and also intracranial interventions. What about radial and brachial for carotid stenting? In fact, the carotid stenting was elaborated as an alternative of the carotid surgery, but mainly with femoral vascular approach. But we know that the femoral vascular approach is not always possible, or even when it's possible, can be very dangerous and very difficult and very risky, like in such a situation like a tortuous aneurysmatic aorta or Leriche syndrome of total aortic occlusion. So potential advantages of the brachial or radial, more radial approach. This is the easy access in complex aortic arch, early mobilization, reduced hypotensive response, no bleeding, we know from the cardiology trials. Anticoagulation is not an issue, even deep anticoagulation, and it's possible to be performed outpatient. But the radial approach is not always possible. There is different success rate, but in between 20 and 30% of the left, especially internal carotids, the radial approach is not easy. So in such a situation, we need a different approach. This approach was created, in fact, as a strategy in 2010. And we were following this publication, following the Claret technique. This is the catheter looping and retrograde engagement technique. And in fact, in following these rules, we are using this situation in order to have a good access to the left carotid system, using floppy wire like the Stork or Uli wire, deeply engaged into the external carotid, and over this loop that is sitting on the right aortic cusp. This is the idea, the loop to sit onto the aortic cusp. So using this loop and using to have access with a Siemens 1 or 2 catheter, we are using to put shuttle sheet, and this is our term is deep loop carotid stenting. So especially in type 3 aortic arch is very easy. What about our experience during the last 2 years of 455 patients of carotid stenting? We have used this deep loop technique in 13%, using radial and brachial approach, so upper approach. I will show you 2 cases. So it's a 76 years old male, very recent case, hypertensive, diabetic, with coronary artery disease and history of coronary PCI. And he had TIA recently, and from the Doppler ultrasound, the gentleman had 90% stenosis of the left internal carotid artery. And I will show you step by step. I'm using this case to show you step-by-step intervention. So on the first step, this is the engagement of the Simon's 2 engagement with angulated terumo protruding into the carotid artery. After having this, we did carotid angio showing really a critical stenosis of the left internal carotid artery. As a next step, I mentioned already the deep engagement of stork floppy wire into the external carotid. This is the introduction of the shuttle sheet that is very slippery. It's a hydrophilic Cook shuttle sheet, 6 French. In all cases, we are using 6 French. So it's a 6 French 90 centimeter long sheet. This is the spider, the distal protection spider crossing this critical lesion. And after the spider was introduced, in this particular case, we made undersized balloon predilation in order to have the stent easier to be placed. So this is the journey of the stent through the deep loop, going on the carotid, on the stenosis of the carotid artery. And on the right side is the gentle 5 millimeter balloon post-dilation in order to treat this particular lesion. This is the final extra and intracranial flow, showing full restoration of the flow for this gentleman. And this is the sheet removal protected with a wire, a floppy wire, in order to spare the vessel wall. Second case, it's a 62 years male, again diabetic with bilateral carotid stenosis, more than 90% by the echo Doppler ultrasound. Unfortunately, in this particular case, we didn't have CTA. Like Gary Rubin mentioned, it's very useful because we can have surprises like this one. This is a so-called arterial lusoria. So it's aberrant right subclavian artery, and you can observe that in this situation it's not easy to treat a patient from a brachial approach and through arterial lusoria, but using the same deep loop technique, we succeeded to, with the Simon's 2, we succeeded to cannulate the right internal carotid artery with this critical stenosis, using the same light shown here with a deep loop sitting on the aortic, right aortic cusp into the aortic sinus. So with this deep engagement again, this is the sheet moving toward the carotid artery. And you can observe here, because you mentioned already how important is the protection. This is the special Paladin system combining in one and the same system the balloon, post-dilation, and a very dense mesh filter, only 40 microns. So you can observe the primary filter up and the secondary filter that is integrated in one and the same system together with the balloon post-dilation system. This is from Contego Medical. And you saw how easily it was introduced via the deep loop formation. So this is the post-dilation of this lesion. And this is the final result, both for the carotid and also intracranial, with quite a good result with this technique. As a conclusion, all we know that the carotid artery stenting is evolving day by day, and the results are becoming better and better. And definitely the old notion for good result, peri-procedural result of 4 or 5% of complication rate is very nowadays our target, the complication rate to be between 0 and 1%. And I think it's absolutely doable using these new techniques. About the deep loop technique, I think that the radial and brachial vascular access in combination with the deep loop technique and 6 French guiding sheet is an acceptable alternative for carotid stenting. And based on our clinical experience, this technique provides a very high procedural success and safety. And thank you very much for your attention.
Very, very nice work, Peter. Oh, Ivo, sorry. Ivo, very nice work. And
thank you.
I'm sorry I couldn't get to your meeting last year, but I had a knee replacement. And
it was a pity.
Yeah.
We missed you. We missed you. Hopefully next time.
So fantastic technique. Of course, we have done this, but I would think we all have to remember the carotid stenting is a little different from anything else. It's not what we can do. It's what we can do with less than 1% stroke death rate. And sometimes as we manipulate more in the arch, in these cases you have to, but most cases from the transfemoral route, type 1, type 2 arches, there's no manipulation at all, and that then decreases that increment of stroke that can occur from the manipulation. But great work, and thank you very much for that fabulous presentation. Good technique to have up your sleeve for sure. Okay, so who we have next, Jan?
I just have to say goodbye. I have full clinic. Gary, so nice to see you. Thank you, all the panelists. Fantastic work from Bulgaria, from Sofia. And Shemek is from Shamrock. That's actually our center. Thank you so much.
Well.
See you later. Thank you.
Thank you, Stefan. So we would like to welcome Przemek Nowakowski, who is a friend. And on a funny note, Stefan is indirectly his boss. I think Przemek may be actually relatively happy that Stefan left. And he's also, Stefan also happens to be a great carotid operator as you are. Go ahead.
I share the screen. You can see my presentation.
Very good.
Yes. Hello, everyone. I am Przemysław Nowakowski. My topic, I'm vascular surgeon from Katowice and Chrzanów, and my topic is connected with carotid artery stenting from radial access. Little bit presentation similar like Professor Petrov, but more generally. When you use alternative radial or brachial access, if we have patient with severe peripheral vascular disease, patient with anatomical variations that make cannulation of the common carotid artery difficult for femoral approach, the preferred approach in patient with bovine left carotid disease, high risk for bleeding and vascular complication, and patient with contraindication for prolonged post-procedure bed rest. We know aortic arch anatomy and free type, and on the right picture we see schematic examples of unfavorable aortic arch anatomy. A, this is type 3 arch for right carotid artery lesions. B, type 2 arch for right carotid artery lesions. C, type 3 arch for left carotid artery lesions. And D, bovine configuration for left carotid artery lesions. In each case, an acute angle must be passed with the guiding catheter to access the lesion of interest from femoral approach. What is important in aortic arch? The highest risk of feature for carotid artery stenting complication are friable aortic arch atheromas in patients with type 3 aortic arch. The symptomatic strokes, about 14 contralateral to the vascular territory of treated, is strongly indicative that catheter manipulation in aortic arch. The highest prevalence of arteriosclerosis distribution is in the descending aorta, followed by arch distal to innominate artery. We use a little bit different procedure technique for right carotid artery, for bovine left carotid artery, and for non-bovine left carotid artery. Start of procedure, radial artery puncture. We prefer right access, 5 or 6 French introducer, intra-arterial injection verapamil to reduce vasospasm, intra-arterial heparin or bivalirudin injection, and forearm angiogram. This is very important point. Why? Fourier angiogram is performed throughout the cannula or the sheath before catheter insertion. This is very important, before. In cases with radial artery tortuosity and radial loops or high takeoff, we can use the soft coronary guide wires. Before main procedure. If before main procedure we was performed CT or MRI, arch, full arch and carotid arteries, we can go to next step. But if not, full aortic arch and carotid arteries angiography is necessary. Typical catheters equipment, Simmons 1 and 2 catheters, PIC and right Judkins catheter. We use hydrophilic long sheet, 5 or 6 French, hydrophilic wires, the Rumac wire, Advantage, and support wire like Amplatz or Backup Meyer. Most uses technique of CCA cannulation, anchoring technique, telescopic technique, and deep loop retrograde cannulation. And few words about anchoring technique. The diagnostic catheter initially passed into the external carotid artery, and usually a diagnostic or transfer catheter positioned into external carotid artery is used for insertion or an exchange length, more supportive guide wire like Amplatz, or over which a guiding sheet is deployed. And picture from this technique, anchoring technique for right common carotid artery cannulation. Picture A, Simmons catheter in right common carotid artery. Picture B, Simmons transfer wire in right external carotid artery. C, picture Amplatz super stiff guide wire in right external carotid artery. And D, shuttle sheet, 6 French shuttle sheet in right common carotid artery. Telescopic technique. With this telescopic technique, a long wire Simmons 2 catheter is positioned within the shuttle sheet and is used as the introducer. This technique is useful for sheet deployment in the cases with extreme angles, such as non-bovine left carotid artery or sharp takeoff of right CCA. And picture from telescopic technique for left common artery cannulation. Picture A, Simmons 2 catheter in left common carotid artery. Picture B, 5 French braided Simmons catheter into 6 French shuttle sheet. And C, final result after carotid left common carotid stenting. And presentation for Professor Petrov, deep loop retrograde cannulation, claret technique is alternative strategy described by Funk. The unique feature of this technique is the use of the right coronary cusp to provide inferior support of the system, but the main disadvantage is the system instability, and particular attention should be made during guiding catheter removal, since it could jump distally during pullback. And few words about proximal protection, yes or no. If you use proximal protection devices, we can use 8 or 9 French devices. Good point is potential lower rate cerebral embolization, but system need training and to be familiar. Recommended technique, anchoring technique for cannulation CCA, and general using proximal protection devices is a sometimes little bit challenging procedure, but not impossible. As you see from right radial access, we use on this picture MoMA to stenting right carotid internal artery. It is technically possible, but challenging. And very important point after procedure, radial artery rescue post-procedure. Radial artery occlusion following transradial carotid stenting is relatively high, and it is at last in part related to use of large bore catheters. Radial artery preservation technique, especially the application of hemostasis devices using patent hemostasis, may reduce this complication, and compression is relatively short, approximately 2-3 hours, with relaxation after 1 hour. Limitation of transradial carotid stenting need extensive and sometimes expensive operator experience. Additional learning curve possibility is related with radial artery size and anatomy, problems with proximal protection devices, and potential problems with air embolization. We use big stents in small sheet and be especially careful and use the vent and reversal flow. And one short case from radial access, 65 years old woman with critical symptomatic left carotid artery stenosis with coronary disease with bovine urge. In angio-CT, we know that patient has bovine urge, and anatomy probably is favorable for radial access. In this procedure, we use telescopic technique and right Judkins catheter. Basic angio show critical left internal artery stenosis. In this case, you use distal protection Robin and angio just before stenting. And final angiogram after stenting. In this case, you use open cell stent MER from Polish company Balton. And last picture from radial access after procedure. Advantages of transradial carotid artery stenting: alternative access in patients with extensive peripheral vascular disease, reduction of access site bleeding and vascular complication, alternative access in patients with anatomical variations that make cannulation of carotid artery difficult from femoral approach, the preferred approach in patients with bovine left carotid artery disease, and using this technique may reduce catheter-induced embolization from transverse aortic arch, early patient mobilization, and probably reduce nursing costs. And disadvantages of transradial carotid stenting: extensive experience with both the transradial approach and CAS carotid artery stenting is necessary. Significant learning curve for new transradial operators, sometimes longer procedure for easy transfemoral approach when cases with type 1 aortic arch, proximal protection and large devices cannot be used freely in all cases, and post-procedure radial artery occlusion sometimes. And as you see, thank you for attention. As you see, sometimes impossible is possible, but only in South Korea, in Seoul. Thank you.
Very, very, very nice. Thank you for that presentation. Yeah, it's a great technique. There is a center in Milano has a very big experience with very low complication rate. I'm sure you know their work. The only other thing I would say is that you can send patients home after femoral stenting. We published that, about 12 years ago now. So you can also discharge patients same day with vascular closure and femoral stenting, but very nice technique. So thank you very much for that presentation. Fabulous. Okay, Jan, where do we go next?
So we go next, but I think we should mention one thing. We used to do actually quite a bit of proximal protection with MoMA, and now we somehow switch into TCAR that we started about a year and a half ago, which is kind of intuitive technique, and perhaps some of the more difficult or higher embolic protection cases. That's what we select them for TCAR. So that's a technique that, or a company, Essential Medical, that hasn't migrated to Europe that much yet, but it's a useful alternative if you're kind of in between.
I think TCAR is also important alternative for any patient with a bad arch. That's the big advantage.
Exactly.
So if they have a unusual anatomy, type 2, type 3, or atherosclerosis, I'm all for TCAR for that. I think it's a good technique. Yeah. So, well, thank you for mentioning that.
Just to mention to Przemek, as a vascular surgeon, and to Grzegorz, that even with TCAR, vascular surgery is still needed because there's issues with deep arteries, as I'm sure you are aware, Jan, and there's an issues with short necks, and sometimes the angle is not optimal. So I want to say I really loved the presentation from Przemek as a balanced presentation from a surgeon. And what I think was particularly important was how careful you are about not losing the radial for the future interventions, because it's not a problem to do the procedure and then lose the artery for further access. In that sense, the feasibility is not an indication. And this is exactly what Dr. Rubin said, that it's not about doing it, but about doing it with a low complication rate and also preserving the access for the future. I think it's extremely important. I think, Ivo, you will agree with this. Yeah.
This is Jan Skowronski. Before we introduce Piotr Musiałek from Kraków, I have to share with you that I used to think that I was a good carotid operator. And I used to take difficult cases to the cath lab for carotid stent. Since I moved to Birmingham, Alabama, and I started having Gary Rubin as my mentor, my case selection really shifted a lot, and I became much more conservative. So Piotr, it's now to you. Piotr from John Paul II Hospital in Krakow. As I understand, you're on call today in a different hospital.
I'm on call in Dartmouth tonight.
I'm glad you're not having a STEMI right now.
I'm 100 kilometers from Krakow. Very pleased to be with you tonight. Just tell me, Jan, what I need to do. So I need to go to share screen. Is that correct?
Yes, you need to go to share screen, and you need to then
go to my PowerPoint presentation. Share. Okay.
You're on.
I'm on. So, spasm in carotid artery stenting. I will not take much of your time. Is it a worry or is it a no worry, Dr. Rubin, or not a worry? What do you say?
I say that if you select your patients very carefully and you use very facile, quick technique, then you don't see it very much. I used to see much, much more. And then if you see it, you can ignore it or give a little bit of nitroglycerin. But there's the odd case, and I'm sure you're going to show one, where it can be very, very severe. So go ahead. This will be interesting.
There's no conflicts. This is Łukasz Tekieli, my colleague and a friend with whom we did the case. I want to present to you today. In fact, Łukasz was doing the case. I was assisting him. He was the good guy. He was the one who warned against the spasm. And this is the guy who actually caused the spasm. And then together we identified and resolved the spasm issue. So as Dr. Rubin has mentioned, spasm in carotid artery stenting is is not a frequent happening, but it can be seen in up to 1 in 20 or 1 in 30 patients. Usually it occurs at the filter site, but it also may occur at the distal edge of the stent. As you can see here, both are benign. It needs to be differentiated with kinking. The treatment of choice is to wait and see. And as it was already mentioned, intra-arterial administration of nitrates or nimodipine that we also use in Poland may accelerate the spasm resolution. This is our patient, a 70-year-old lady, diabetic with peripheral arterial disease, with a history of MI and primary PCI, with a history of right internal carotid artery associated stroke that was later treated with carotid artery stenting. This is the left internal carotid artery. You can see on the screen, she's on optimal medical therapy. And despite the OMT, she has progressive stenosis of the left internal carotid artery. The lesion is at this point in time clinically asymptomatic, but there is an evident progression. There's no diffusion weighted or flare changes in the left hemisphere, But as you can see here, there is a thrombus-containing lesion in this left internal carotid artery. So the first question we'll always ask ourselves is, do we need to treat this patient? Does the patient have an indication to intervention? What do you think, gentlemen? To treat or not to treat this carotid on optimal medical therapy that is progressing? We do not have a chance to randomize to CREST-2 in Poland. We have to make choices based on what we believe is best for the patient. Would you treat or would you observe this lesion?
I would treat, but I would put the patient on high-dose statin and high-dose dual antiplatelet therapy, and maybe some antithrombin therapy for about 10 days, because I've seen this clean up and make it a safer procedure. If a patient remains asymptomatic, I think it's defer, not to treat, but defer with some extra medical therapy.
To pacify the lesion, and this is in fact what we did. She was on no molecular weight heparin for 14 days before the procedure. Przemek, do you do endo or open surgery in this case?
I think endo for this patient.
Endo.
Yes,
And
but dorsal stent, maybe wall stent, oldest stent, but good stent, oldest.
If you allow me, it depends on the calcification. In case you have a circumferential calcium, it could be a problem. So it's probably one of the biggest contraindication for stenting is calcium. So you have to rely on a good color Doppler angiologist. So in order to tell you, is there a calcium or not?
This is a mixed plaque with a lot of soft tissue in it. So if you decide to intervene, then the next question is the strategy. To shorten the presentation, I would like to tell you that our strategy in those cases is proximal protected stenting with a micronet covered stent. And arterectomy is, of course, fully acceptable. TCAR that we also have experience with is fully acceptable. But in that case, my surgical partner believes that if endo or TCAR, they need to be combined with the micronet covered stent. So no conventional stents in those high-risk lesions in our center. The strategy was to use a standard BMW wire to predilate, then to use a self-adapting or SmartFit micronet covered stent, 7x30, and post-dilate with a Sterling 4.5 balloon, so not very aggressive post-dilatation. You can see the flow reversal. A lesion was crossed under flow reversal, pre-dil, stent placement, post-dilation. Back pressure was 35/28 millimeters of mercury. The patient was intolerant over the last 3 minutes, but this is not a problem for us. We expect in those patients with low back pressure intolerance, and then normally after you come back to the normal flow, the intolerance resolves, and this was in fact the case in this patient. You still aspirate even if the patient is intolerant. And this is the final result we had. So what do we do now? Do I remove the wire? Do we finish the case? What do you think?
I think we would remove, well, I don't know about the wire. You're doing it with proximal protection, as I understand, right?
Yeah, you can still see the MoMA deflated balloon in the external carotid artery.
Yeah. I would just give a lot of nitroglycerin.
Okay. I like it.
Yeah, and wait. So, sometimes if you pull the MoMA sheath and everything back a little bit, so you can let the more cephalate vessel relax too. So it's another good thing to remember.
Thank you for
this comment. When you advance the MoMA and when you advance a sheath, you are pushing everything hard up against the base of the skull. So, yeah.
Correct. So you would expect there's an element of kink also in the spasm?
Maybe. Yeah, you can see it on cephalate too.
Definitely, you know, it's we decided not to immediately remove the system, but to see what's going on. So we gave some nimodipine, nitroglycerin, then nimodipine. It did not improve. We decided to use IVUS to see what is happening there, to be sure we can safely remove the wire, because once we remove the wire, we may never be able to come back again. This is the IVUS image. This is just distal to the stent. You can see the chroma flow, and you can see that something's happening between 2 o'clock and 6 o'clock in this IVUS image. And then if you look at the next frame, it's even more. It looks like a tear that is there. And in fact, in a while we had this image. So it looks like, you know, maybe there's more spasm. But in fact, what was happening, we went again with the IVUS catheter, was the extension of the false lumen that you can see between sort of 6 and 9 o'clock here. So this was clearly a dissection that was mimicked as a spasm of the vessel. In the stent, there was, not surprisingly, you see less red, less flow. The stent looks very good. There's no plaque prolapse to the stent, but there's of course less flow. The patient became symptomatic. This is the picture you can see on your left, very thin true lumen, large false lumen, and the flow very, very little and very, very slow. We were fortunate to have left the wire in the true lumen. The dissection was momentarily fixed with another stent under flow reversal that we reinstituted. And the question is, was this the end of the story? Ivo, what do we do now?
It's quite difficult to decide. In fact, I wanted to ask you, was it tapered stent or tubular?
No, this was a smart fit. This was a Seagard stent, a smart fit stent.
Aha, the Seagard. So I don't have very much evidence. There is no very much science, but I prefer tapered stents because they are following better the anatomy. And I think in such cases in which the distal edge of the stent is oversized in relation to the reference, to the distal reference, it can cause dissection and even extensive dissection like in this case.
This is definitely true for the conventional stents. For the exact stents, we also used a lot of the tapered stents. But as you may know, there is a study from Germany using a 10 by 30 Seagard stent in all-comer lesions. And this is how they really proved the smart fit design without dissections. And this is the first dissection we had in our nearly 500 cases. So you can look in the radial force. They measured, Christian Viscott, they measured the radial force of the stent across the lesions. And they came up with this message that, in fact, this was 7 by 30 in this case, that 10 by 30, because of the smart fit adaptability, is a potential solution for they say all types of the lesion. But also we do size our stents currently in the carotids. But my question is, what's happening here at the distal edge of the stent? Do we have bad luck again? What do you think?
Well, you tell me, were you sure that you deployed the distal end of the stent into normal vessel or not?
Well, it looked like we did, but we did not do IVUS before. The question is, it's a very important question, was there a plaque there? It does not look like there was a plaque there from the IVUS image. But now we have the second stent that is implanted, and you see this image at the distal edge of the stent. Yeah,
well, I would suspect spasm, and I would treat it aggressively before putting another stent in, because if the artery, the carotid artery, is very prone to spasm. It's also, if you're very gentle, it's not very prone to dissection unless you're doing something wrong. It is prone to kinking and spasm, and there was a little bend up there, and so maybe give a lot of medication, see what happens.
Yeah,
That's
so this is Jan. I share Gary's sentiment. I think it's a combination of most likely spasm and kink. So I would treat with nitroglycerin, or as I can see, calcium channel blocker IV. I think that's appropriate. You still have a wire through. Thank you.
So as you can see, the spasm resolved. There are those people with catastrophic ideas that if you're lucky, if you're unlucky, there's always a chain of problems. But we believe there's the end of the problem, and in fact, it was a spasm this time that was fully resolved. So what actually happened? What was the problem, and why did it occur? This is what Lucas did. This is how he placed his balloon when he was performing post-dilation. And this is okay, because you can see that the marker of the balloon is below the distal edge of the stent. And he was right to do it that way. And then you can see here the distance between the stent and the balloon. So the balloon is not causing any injury to the vessel. But now he told me he didn't want to perform this inflation. He said, look, I'm out, Piotr, I think I should pull back. To which I said, no worry, it's never happened. I don't think that's going to happen. We'll be okay. And the mistake was mine in this case, because what you see on your left is okay, but what you can see on your right is not okay, because you can see the balloon hanging from the stent to the vessel. We have a saying in Polish that you may have learned from Jan, Dr. Rubin. We say, oh, okay, if something like that happens, which is a bad word, but definitely it is not okay. So the take home, what are the take homes? Always consider the worst scenario. Do not think that you are lucky until you prove that you are lucky, because if you are prepared, then you can hopefully exclude the problem. Be or become IVUS conscious and IVUS friendly. IVUS can save the patient and can save your A, as you have seen in this case. Thank you very much for attention.
Beautiful case. Yeah, very, very
beautiful case. Back to you.
So now we are live, and Mr. Gary Rubin is with us in a small frame. So thank you very much, guys. And Jan is coming back. Thank you. So it was the last session, and it's a very good moment to say goodbye.
Yes, Jan, do you hear us?
Give him a second.
Yes.
What do you think about the conference?
I am really happy. I didn't imagine that it could happen. When we decided with Jan to prepare this webinar, and when we started to prepare the schedule, and so when we saw that it takes us 6-7 hours, I couldn't believe that
it's too much.
Maybe it's too much, but I didn't believe that it will work.
Yeah.
But after this long day, I see that it was so interesting. But why it was interesting? Because we collected so interesting people.
Yeah.
Because the content is most important, not the titles.
When I was working in regular TV, the biggest one in Poland, my boss told us every day that content is the king. So that is why.
Sure, yeah. But the content, I mean, the people together with Jan, because Jan knows many interesting people in United States. We know also the people from Europe and from Poland. So I think that our success is to take those people together and make this presentation.
And fight with the whole online world. It's not easy, especially at the beginning when we try to do something for the first time, but I think that at the end of the show, at the end of a very long day with Icarus, we can say that we did it. So thank you very much to all participants. Thank you, Grzegorz. Thank you, Jan.
Jan, do you hear us?
Thank you so much. So just a brief summary, but I will start by obviously wholeheartedly thanking my co-host Grzegorz Oszkinis and Jarek Kuźniar in Warsaw and his company, and Will Hightower here in Birmingham, who was indispensable and on a really, really high level. But I will also continue with a question to Grzegorz. Grzegorz, what have you learned today?
I've learned that even impossible could be possible. This is the first one. And but also, what was interesting that we took together the cardiologist, angiologist, vascular surgeon, and we share our knowledge and we share our practice together. I think that it was for the first time in Poland that so many specialists which are working in peripheral problems, we took them together and we share our experience. I think this is great. I think this is the future. Probably we will be able to meet personally in Warsaw, for example. I don't know if it will be in autumn or next year, in the beginning of the next year. But I think that we have to do that, and we have to continue our Icarus conferences.
So let me take over for a second. So let me share what I learned. First of all, I learned that we are one global community. We cannot see each other due to obvious reasons, but when we look at cases, we had impressive cases from Bulgaria and Poland and England and the United States, and we kind of almost do the same. But even technically, I learned a lot, especially personally, technique-wise, the cases on critical limb ischemia. I think the most interesting part was that Mikołaj Wojtaszek learned this technique from Twitter. And I think it also teaches us a lot, that you can just use social media. You don't necessarily have to travel somewhere. You don't have to train. You can just go on someone's Twitter account and see a smart case by another operator. I think we also learned that international societies or any societies grouping us, whether this is on Twitter or Facebook or a formal society grouping people of one specialty, helps a lot. I think I personally also learned that COVID, in a way, it's also a positive thing for us as a group because it brings us together. And I think with this absolute expansion of online knowledge, and I definitely would love to continue. So thank you very much from Birmingham, and back to you briefly in Warsaw. Thank you.
Thank you very much.